Hello, my name is SKing and I'm here to introduce you to a deadly predator. This predator targets women more often than men, particularly elderly women. May not be recognized immediately as a sign of a threat. May attack silently without any sign of danger. When there are signs of danger, they are often overlooked. Cardiovascular disease is the #1 killer of women. Despite a growing awareness of the threat to women, women are still less likely than men to be recognized as being at risk, receiving a thorough evaluation, and appropriate intervention. Cardiovascular disease is an umbrella term that includes coronary artery disease, cerebrovascular disease, peripheral artery disease, deep vein thrombosis, pulmonary embolus, and congenital heart disease. In 2008, cardiovascular disease was responsible for the death of more women in the U.S. than all forms of cancer, chronic lower respiratory disease, and Alzheimer's combined. 1 in 8 or 9 American women aged 45 to 64 years has clinical evidence of coronary artery disease. This number increases to 1 in 3 in women older than 65. 36% of American women aged 55 to 64 years and 55% of those over the age of 75 are disabled by symptoms of their illness. Coronary artery disease is responsible for over 250,000 deaths each year. More women than men now die of coronary artery disease each year in the United States. Coronary artery disease is more dependent on age in women than it is in men. Women are typically 10 years older than men when symptoms first appear, and the incidence of heart attack or myocardial infarction occurs as much as 20 years later in women than in men. Risk factors include physical inactivity, obesity, diabetes, hypertension, hyperlipidemia, smoking, age, and family history. People that are considered high risk have 1 or more of the high risk states, including clinical manifestation of coronary heart disease, cerebrovascular disease, or peripheral artery disease, or abdominal aortic aneurysm, end-stage or chronic kidney disease, diabetes, or a 10-year predicted risk of cardiovascular disease greater than equal to 10%. People that are considered at risk have more than one or more of the major risk factors, including cigarette smoking, hypertension, hyperlipidemia, poor diet, physical inactivity, family history, evidence of advanced subclinical atherosclerosis, or poor exercise capacity on a treadmill test, as well as history of gestational diabetes, pregnancy-induced hypertension. Ideal cardiovascular health includes all of these. Normal cholesterol, normal blood sugar, abstinence from smoking, physical activity at goal for adults, and a healthy diet. A sedentary lifestyle is the most common risk factor for CAD in women. 39% of white women and 57% of women of color do not get enough physical exercise. Rates of physical inactivity are highest among poor women. Physical inactivity contributes to obesity and is an independent risk factor for myocardial infarction. Modest exercise has been strongly associated with risk reduction. Obesity is also a major risk factor for the development of type 2 diabetes, which is the most important risk factor for CAD in women. Hormonal influence on cardiovascular risk plays an important role. Pregnancy and menopause are included. The updated American Heart Association guidelines recognize that the metabolic and cardiovascular stresses of pregnancy provide a unique opportunity to assess a woman's overall lifetime risk of cardiovascular disease. Preeclampsia in itself may be viewed as a failed stress test. Cardiovascular evaluation should always include a detailed history of preeclampsia, gestational diabetes, preterm birth, a birth of an infant small for gestational age, or pregnancy-induced hypertension. The menopausal period in itself appears to be a time of transition to increased cardiovascular risk. The incidence of non-diabetic CVD is lower in premenopausal women than it is in age-matched men. Ovarian hormone insufficiency at the time of menopause is associated with increased cardiovascular events. These observations have led to the development of a hypothesis that estrogens protect women against atherosclerotic complications. Estrogen has shown to lower low-density lipoproteins, or LDL, increase HDL, the high-density proteins, and increase the release of vasodilators such as nitric oxide and prostacyclin from vessel walls, which results in inhibition of vascular constriction and lowers blood pressure, as well as decreases platelet aggregation. You may wonder why we don't use hormone replacement therapy to help with these increased cardiovascular risks in women. One study of hormone replacement therapy showed that estrogen therapy decelerated the early stages of atherosclerosis. Late initiation of hormone therapy was not associated with any cardiovascular benefit. The trial was discontinued early due to increased risk of coronary heart disease and stroke. Hormone therapy in men was associated with severe adverse vascular effects, as well as increased cardiac-related deaths, and a long-term use of hormone replacement therapy can be contributed to increase in breast cancer. Women do not always present with characteristic chest pain. Atypical symptoms include atypical chest pain, abdominal pain, dyspnea or shortness of breath, nausea, fatigue, diaphoresis. Silent myocardial ischemia is more common in women than it is in men, which would be a silent heart attack, silent MI. The differences in symptoms often cause women to delay seeking medical intervention and emergency care and life-saving interventions. Testing for cardiovascular disease in women can be different as well. Electrocardiograms, or EKGs, and stress tests are less sensitive to changes in women than they are in men, making it more difficult to diagnose. Echocardiograms and radioisotope testing can be complicated by the effects of breast tissue on the imaging. Catheterization, or angiography, shows that the plaque in women tends to be distributed diffusely rather than in clumps like it is in men, causing women's angiographic studies to be misinterpreted as normal. Women also have smaller vessels, which makes it harder to revascularize. Medications that are prescribed to men are often underprescribed in women. Cardiac catheterization, coronary angioplasty, and coronary bypass graft surgery have been less frequently performed on women than they are in men. The medications such as beta blockers, aspirin, and lipid-lowering agents are underprescribed in women. Keep going. Prevention and intervention should focus on blood pressure control, diabetes management, and achieving optimal lipid levels. These are central for major risk intervention intended for women who are either at risk or high risk for cardiovascular events. Lifestyle interventions focus on smoking cessation, physical activity, cardiac rehab, and dietary intake. Weight maintenance or reduction is also important. Physical activity recommendations include performing at least 150 minutes per week of moderate exercise and 75 minutes per week of vigorous exercise, at least 10 minutes of aerobic activity per episode spread throughout the week. Advise women to eat a diet rich in fruits, vegetables, whole grains, and fiber. Fish, and preferably oily fish, at least twice a week. Limit saturated fats, cholesterol, alcohol, sodium and sugar, and avoid trans fatty acids. Women are advised to maintain an appropriate BMI and waist size. Understanding potential differences in cardiovascular disease presentation as well as response to treatment may help to further raise awareness. Patients and caregivers need to be aware of preventative strategies and lifestyle changes that promote cardiovascular health.